Thank you. I would like to thank the Society for the privilege of the podium and everybody staying on this, what seems like a nice Friday afternoon, to hear about this talk on robotic general surgery. We have no disclosures. As way of introduction, so robot-assisted surgery has been prevalent in urology and gynecology since about 2000. It was estimated that open prostatectomy rates in 2003 approached 95%, that in 2013, robot-assisted prostatectomy rates were almost 90%, really showing what the trend was there, which is also echoed in the number of Medline search results, if looking for robotic publications, really a testament to the growing interest in the robotic technology. And with that, the robot has also been gaining popularity in general surgery. And while there is currently no general surgery procedure that is done primarily robotically, perhaps what has been happening in urology could happen also in general surgery. So this then poses an interesting question, similar to what happened at the end of the 1980s when laparoscopy came into general surgery. How are surgeons best trained in adopting this new technology? And some of this has given rise to literature on the learning curve in robotic surgery. And just to speak a little bit about the learning curve, additionally, it was conceived in the 1880s, looking at repetitions needed to decrease task completion time. And over time, the curve has now, this traditional curve that you see here on the right is really more change in performance over time, where there is still some fundamental learning to be done about how to perform a task. There's a sort of slow beginning, then as the pieces are put together and performance become more facile, there's a steep acceleration and improvement in performance over even just a few levels, over a few new attempts at performing the procedure. And then ultimately there's a plateau when additional practice really doesn't lead to any improvement in performance anymore. And this is just to give you a little bit of context of what the learning curve is about. So the aim for us then was to review the literature on the learning curve for robot-assisted general surgery, to see just what the data show and how this perhaps can be used to inform surgeons and credentialers as you try to adopt this technology. So we performed a PubMed search using the terms robotic surgery and the learning curve. This yielded 647 results. We reviewed the titles and abstracts and excluded articles if they were not in English, did not address general surgery procedures, were reviews, meta-analyses, or commentaries, or importantly, if they lacked an explicit statistical method. That left us with 25 articles, one of which didn't treat a specific procedure, but sort of was a hodgepodge, so we excluded it, leaving us with 24 articles. These primarily covered colorectal surgery, followed by foregut and bariatric. Solid organ was less represented, in biliary surgery, again, much fewer. So I'm actually not going to be talking about biliary surgery at all because the articles were quite different from the other ones that I will be talking about. So the primary measure that was used in the papers universally was procedure time. And some papers did make an effort to look at surgical oncologic aspects to determine the learning curve. Also, blood loss, lengths of stay were represented, but much fewer. But given that procedure time really was the universal measure, I'm going to be focusing on this for the remainder of this presentation. So this is just a representation of the number of papers in colorectal, foregut, solid organ that identified a multiphasic learning curve, such as one that I showed you earlier. So 10 papers actually found a multiphasic learning curve. Predominantly in the colorectal surgery literature, perhaps not surprisingly, because most of the papers came out of that. The remaining papers, the remaining 14, mostly showed a single cutoff of when performance improved. And because of how the learning curve was mapped here, it's sort of more analogous to the initial definition of the learning curve that I showed you before, that is performance time mapped against performance number. So there's an initial learning curve that starts with long OR times, and then as performance becomes more facile and the robot mechanics are sort of grasped, the OR time decreases. Then and then the literature sort of reports that as surgeons get to that level of facility, they start adding more complex cases or patients with more complex anatomy, which then causes a rise again in OR time. And this is what in the literature is now referred to as the challenging phase. And then when surgeons hit a spot even with challenging cases where they are now good enough with the robot, then the OR time starts to slowly decrease again, representing the expert phase. So how many cases are needed to get to stable performance? And is perhaps the most relevant here. So for the initial learning phase, which here includes all the literature that identified a triphasic learning phase as well as a single cutoff, the mean number of cases for colorectal surgery is 31, and mean number for both foregut and solid organ is 37. As you can see there that there's a wide range, but the means are clustering in the mid-30 range. And then focusing just on colorectal surgery, since there was enough papers to sort of look at a mean and have it be meaningful, it seems that the expert phase, at least for colorectal surgery, begins at around 67 cases, again with a wide spread. So in summary and conclusion then, the time-based learning curve determination really predominates in the literature. It's not surprising, again, because the learning curve originally was conceived as a time-based concept. However, there has been some effort in the literature to look at patient outcomes, which perhaps is more relevant. And so as people start to write more about the learning curve, maybe we should encourage that those are the outcomes that are more looked at. And then as one thinks about adopting the robot, it seems that time-based alone, an average of 31 to 37 cases are needed to complete the initial phase of the learning curve, and the expert phase, at least for colorectal, seems to be somewhere around 67, but is individualized based on the type of patients surgeons take on after they complete the initial learning phase. Thank you very much.